While we are waiting for more people to join, I will start with introducing with our speaker, Dr. Alexander Caudarella. He's a substance use physician and family physician. He's currently the medical director for addictions at St. Michael's Hospital. He's a previous member of the Ontario Opioid Task Force and a current member of the THSN TPH Opioid Joint Task Force. His areas of interest include innovative program development for substance use care in hospitals and low resource areas. Dr. Caudarella has extensive experience in substance use, having worked in BC, Ontario, and Nunavut, as well as ongoing international work. And I'm really excited for his talk because I think management of acute pain for patients who have concurrent opioid use is always an area that comes up quite commonly in primary care, as well as concurrent stimulant use. As we all know, unfortunately, the opiate related deaths in Ontario continue to climb rapidly each year. New data shows that stimulants are playing a significant role, particularly methamphetamine and powder and crack cocaine. So I'm really excited to hear his wisdom and expertise around screening for concurrent stimulant use and management. Thank you, Alex.
Thanks for having me. Thanks to those in our session. So, really, what I'm hoping to do today is to have a discussion about how you can make your clinical practice better. Some of this from the literature, some of this is what we learned from working with our clients and lived experience, and some of it's just through experience, some of what we've brought on and been able to do. But I am really hoping that this can be as interactive as possible. I'd really like for people to share their experiences. For example, if they're finding that something they've done has worked really well, in addition to what I'm suggesting, I think it'd be wonderful if you can kind of just throw that in the chat and share the wisdom amongst us. It, we're going to cover 4 or 5 different areas that I have found to be key considerations that sometimes we don't think of, or most people don't think of when dealing with opioids and people who use drugs, and how we can make it a little bit of a safer and better place for people to be. So, like I said, I'm the medical director right now at St. Michael's Hospital in Toronto for substance use services. I'm the physician lead at ICHA, the Inner City Health Associates, which is a group of physicians in allied health who work in shelter-based settings. And I've worked in a kind of a variety of different spots across the country. I don't have any commercial interests. I do receive funding from CIHR as well as the governments of Ontario and Nunavut mostly for program development and research. The objectives. I want us to kind of realize some of the obstacles people who use drugs face in accessing care, identification of particularly high-risk subgroups, and development of more comprehensive communications strategies, as well as a tool, just sharing a tool I really like to use around how to do a good functional analysis when it comes to somebody's substance use. Now, all of this is with the caveat that I'm a physician, I'm not a person with lived experience, and I'm really thrilled to see how much of the conference this year includes the voices of lived experience and people from differing backgrounds. Um, so obviously this is one piece of the experience, but by no means should be the exclusive one. I'm wondering if you can just take a minute right now, actually, and just think about the beginning of your clinic day, or the beginning of what a day might be like, either if you're working the emerge or wherever you're setting in. Just even close your eyes, take a quick second, you've taken the transit, you've taken a car, however you get there, and kind of what are your steps going through the door and to get to your office or wherever you're going to be seeing patients. A lot of it becomes muscle memory. We don't even think about who we run into and who we see. This was something a patient told me years ago, and it's been repeated to me in various forms. People just want me to die. First time I heard it, I took it to mean people don't, like, the general public doesn't care if I live or die because my life has less value as a person who uses drugs. When I probed, it really, for a lot of the clients I work with, is actually a deeply held belief that not only do people don't care if they live or die, but people actually actively want them to die because then they feel that from their perspective, society would be better off. So it's just kind of the level of stigma and deterrence from seeking care that I think so many of the people feel. And this is kind of the wall that we're pushing against, that healthcare for most people is not only not an inviting place, but they feel is a place that's actively trying to hurt them. So now in that context, I'd actually really like, again, can you take 1 second to just think about what is the experience for a person who might be intoxicated or in withdrawal, who might have had criminal justice involvement historically, who might not be trusting of healthcare services either because of stuff that's happened or even stuff they've heard that has happened. I just want you to really think, what is the experience in terms of seeking care either for the first time or for other times as people go through it? What's the very first moment when they come through the door? What's the very first thing that they see? Who is in the waiting room? Who are they going to encounter? What is the check-in process like? Is there a security guard there? If so, how is that interpreted? Maybe some staff might make him feel safe. If there are safe needles and supplies, where are they and how are they accessed? How does somebody need to ask for them? Are they going to feel more or less shame if they ask for them, or what's going to happen? Even just the check-in process, like we often sometimes forget when we're developing clinical programs how much actually occurs even before the patient sees the physician or healthcare worker. And this was from a study that was done in the United States, but I think a lot of it rings true. So this was amongst, in the United States, you need a waiver to prescribe Suboxone. So these are people who've done the training, gotten the waiver, and this research team attempted to call 10,000 people who had waivers. And as you can see, in thousands of cases, they were either told that they don't provide addiction treatment or they couldn't get past the appointment registration system. A lot of the times, they were actually just told things that the clinic felt about people who use drugs. And so, unfortunately, it just shows at every step there's a lot of stigma and problems that people might face. What are your hours? Again, this is kind of in the context that 25% of opioid deaths are occurring and associated with people in the construction industry. And then lastly, I think the thing that to think about is, who is your competition? This is something we don't actually think about a lot in the context of substance use or in the context of healthcare at all. We don't really think of ourselves as a business or competing. But when we ask ourselves, who is your competition, not in terms of other clinics, but when the person is deciding to come and seek healthcare, especially if you're providing something along the lines of treatment, the alternative is very frequently a person who's selling drugs, selling illicit drugs to them, a person with whom they have often a long-standing relationship, a person they trust a lot, and often somebody who will just come to their house and come at any hours. So that's really what you're up against, and who often the alternative versus coming in to see you is. Just wondering if people want to drop in the chat any observations or thoughts they have about their clinical spaces in terms of what we were just talking about, especially around who are people seeing, how are your waiting rooms and areas set up, and is there anything that kind of comes to mind? Especially again, what kinds of people might they meet and what kinds of questions might they be asked? Just curious what people think and what they've experienced. Again, like our focus had really been on the programs itself until we spoke to a lot of the people with lived experience who work with us directly and said, your focus is kind of on the wrong spot. Your focus really needs to be on the time that people spend even before they come and see a physician. Oh, my clinics look like little holes in the wall, so to speak. My mission is to increase access, is to go where patients live. Having a clinic once per week means keeping costs down. Yeah, and you know what? Like a lot of the really interesting things that have been done are around trying to bring care to people and to their living environment. but yeah, so that's interesting, and if it's bare bones, I guess what is the question becomes, where do people end up waiting, and what is that experience like for them? It's actually kind of encouraged. I actually just will sit in my own waiting room sometimes, which I didn't used to do before, but I'll sit um, uh, either in my own or other people's waiting rooms, and actually for like extended periods of time. Used to buy pizza. Well, that's nice too. I mean, often provision of food or drink or something like that can really go a long way. Absolutely, can happen. Thank you so much, Brad, for sharing this. It's a really good ideas, and even sometimes having a really bare bones clinic doesn't necessarily mean it has to be an uncomfortable position, a place for people. Um, but there's a lot of options. I want to look at it. And if other ideas or suggestions come up, you can throw them in the chat. What's for stigma reduction initiative, the food insecurity, of course. Yes, absolutely, Brad. Thank you so much for sharing that. Such a good point. I want to focus actually on one overlooked priority population. So this is from the ODPRN, who's also presenting in this conference around the overdose deaths. And one of the things Ontario does that other provinces don't do is they try and figure out which substances are direct contributors to opioid-related deaths, as opposed to simply just in somebody's bloodstream. And I want you to just look at the bottom part of the stimulants. To me, this is like the scariest graph that's out there. 58% of people who die of an opioid-related death in Ontario, it is felt that the stimulants in their system contributed to it. We have in our country, and actually in North America, truly a two-tier substance use support system. And it's two-tier in many different ways. People have to pay for a lot of things, but what I'm talking about is there's the category if you use opioids, the pathways are clear. There's OAT clinics, there's support, and then there's everything else. And I want to talk a little bit about some of the challenges, particularly stimulant using patients are experiencing, and maybe get you to think a little bit about, am I doing as much as I can in my work with people who use opioids to make sure that I'm making this as inviting and comfortable a place for people who use opioids and stimulants? Okay. People who use stimulants, they both over and underutilize the emergency department and struggle to follow up on no medicine. That means they're often going for things that they cannot get support from the emergency department to the emerge. But then when they need care or with life-threatening issues, they're often not going to the emergency department. And weekly methamphetamine users are actually 6 times less likely to go to primary care follow-up, even compared to other people who use drugs. There's a lot of reasons for this. Trauma, fear. It's important to remember up to 40% of people who regularly use crystal methamphetamine may be actively experiencing psychotic symptoms. And although there isn't a distinguishing feature of substance-induced psychosis, there are very frequently some paranoid or persecutory delusions, which are in and on top of all the fears people legitimately have of the healthcare system. There might be some element of intoxication or withdrawal, and it can be a lot more subtle than opioid or alcohol intoxication withdrawal. They're not going to get treated in the emerge for these things, but it makes them a little bit more irritable, more tired if they're in withdrawal, and just very, very uncomfortable. Unfortunately, the stimulant use itself can be directly linked to disorganization in various forms, makes following up very difficult. And unstable housing is unfortunately a very frequent repeating factor in this patient population. So my first and most important thing is, if it's at all possible, move these patients to a low light, low noise, and low stim area, regardless if they're intoxicated or in withdrawal. You would not believe, like when we'll look even in the emerge, when we look at our CTAS 2s and 3s, fairly high priority patients, how many actually leave without being seen. And I understand you can't always see everyone very quickly, But if you can create an environment where the person isn't overstimulated, you can do two things. You can, first of all, do a lot to prevent escalation of these clients and behaviors that might be problematic, but also help them stay longer and actually seek out care. Because we know a lot of opioid treatment in this province is drop-in, and yet still stimulant patients aren't making it and they're not staying if they're there. I can't remember the last time I was in an opioid clinic that didn't have bright lights and white walls and a lot of noise, either from the outside or different things. And so sometimes it can even mean just popping somebody in a room, or I think, like Brad was saying, getting them something to eat. Um, I mean, one of the realities is that methamphetamine use, unfortunately, is directly neurotoxic. It happens with all stimulants to some degree, but it's a big concern. And here's some of the mechanisms by which it happens. But really, the, the effects can be significant. You don't need years and years of use for it to become a big problem. We often will see, even after a couple of years of periodic stimulant use, that there have been manifestations of impaired cognition. And why do I bring this up? I don't bring it up in any way to try and diminish the autonomy or decision making that people have, but I think it's really important to recognize that especially stimulant users, especially methamphetamine users, are going to have broad, at least moderate cognitive impairment in some of these areas. Impulsivity and social cognition, I think that makes a lot of sense, but that also includes emotional facial recognition, but also attention, executive function, language, and verbal. So again, it's not to restrict this patient's autonomy, but you kind of have to work with people who use drugs in a similar way that you might with somebody who has some degree of an acquired brain injury. And I think our approach to working with clients who have some impaired function is often very kind and considerate, but our experiences working with people who use stimulants is often very different. We get upset more frequently and more easily. We get frustrated with them. Part of this is the fact that they'll often look young and healthy on the outside. And they often come in maybe with a lot of demands and maybe not able to express their needs. And so some of it is just even coming from it from a lens of compassion and understanding that frequently they are struggling and having difficulty expressing themselves appropriately. So from the literature, and I found this really useful, speak in short and simple questions, sentences with repetition. For those of you who work with trainees in any form, I find these next three tips, which I actually got from a nursing journal, to be the most helpful. And a lot of the times, so let's say there's a nurse before seeing a physician that has to do a bit of an assessment, or let's say there's a resident that's doing an assessment. There is always a desire to grab as much information as possible. And the problem is that that can shut down the conversation very early, but also can make somebody experience something in a different way than they are. And to the degree to which people can hide not only their impairment, but also even psychotic symptoms that they're having it. Like, I could tell you once I had a patient, one of my patients who used a fair amount of Tina, crystal meth. I got a call from the emergency department. Said your patient's here. He's doing well. Um, he's happy to be in the emerge. He's looking for this. We're thinking about discharging him. Totally normal conversation. I then got a call on my cell about 1 minute later from the same patient they were just talking to me about. And they said, Dr. Alex, like, I'm so worried. All the nurses have been replaced by cops. And it just shows like how forwardly praising they can be presented, how well they can present. And so try not to overload these. So these are the three questions I love to ask myself. Do I have to have this conversation now? How much of the history is really important to gain, especially from a safety point of view? It can be really tempting, especially when the person's somewhat combative, to try and give advice really early on. Again, we're talking about an overstimulation. So really working to try not to counsel or give information too early can be really important. And lastly, and this one's actually hard, don't take what is said personally or as an attack. Try and recognize what's being said. It doesn't necessarily mean tolerating any behavior, but just try not to take it personally. because these kinds of things are having impact, and especially if the person is having difficulty picking up on emotional cues, that's how we respond and expect people to adapt. So that's a big limiting factor there. This one's probably the hardest because if this person is struggling to get across to you what they want, and they're not really understanding why you can't provide it for them, you can repeat over and over why you're not able to do something and find that the conversation can't move forward. If you're able to actually try and pivot the conversation and really, really focus on what you can provide, it can go a long way. If you're going to talk about what you can't provide, again, think about it in the context of the trauma that many of these people have experienced, not just in their own lives, but I talk about trauma more in a broad way from the healthcare system and how much of a black box it can be. Try and explain to them. I found people really receptive to why you're not able to provide X that day and what could happen that would allow you to change in the future to revisit this. Provide ample personal space. This one's really, really important. Bigger rooms. You know how sometimes as clinicians we're thinking about where's our exit strategy? It's the same thing for especially people who use drugs, especially if they're feeling a little bit paranoid. They need a way out. They need to feel that they're safe. They need to feel that their stuff is safe. Lots of love, care, and support has often been something that's been missing, and it's not something that people are going to ask for. So anything, and going back to that statement about not just people don't care about me, but people actively want me to die. The only way we really get to counter that is by reminding people that they have value. I know this sounds corny, but like it means so much to actively say this as a physician. So that's why I keep repeating it. Reminding people that they have value as human beings, that you care about what happens to them, and that they're important people to you. When we talk about, and the other part I love to do is motivational interviewing. When I talk about motivational interviewing, what is motivation? What is change? It's three things. It's your readiness to change, it's the importance of the change, and it's your confidence. And if those people don't have confidence, it may come across as I don't want to make any changes in my life, but this is how you do. And then as food, if you can, food insecurity being huge, right? People who use stimulants are often going to go days without eating anything. It is a significant appetite reduction. And so I like that Brad was putting in the necessity for pizza. Actually, there's a follow-up question. What would be some high value things you would offer patients? Yeah, ideally inexpensive and tax deductible. Often, um, what we will do, if we can, is ask people what they need the most and try and go there. I mean, I think people like as much as you can if you can trust them with something like even low denomination gift cards, and you can even with those gift cards ask them to if they want to bank them with you so that you can give them and then give them all at once in a larger amount later on or smaller amounts. Socks. Leah brought up socks. Such a good point, right? Socks, food, and especially sometimes it's even like not only healthy food, it's just something that they can really enjoy. Like the number of times people love chips and things like that. People also are bored. That's why like trying to reduce their stimulant use is trying to adjust boredom. Like the number of times people have asked for cheap adventure novels because they just want to read something, um, or coloring books. Like the number of times people love like dollar store coloring books can just go a really long way, not just in the waiting room, but in general. And I love the idea of socks. If anybody else has any good ideas of what are cheap items that people can put, but I find some healthy food, but yeah, junk food too. Yeah, any appetite from a local business to do some donations? I think that's it's a great idea too. Trying to seek from local businesses what they might want, but often asking people what they feel that they need the most. I mean, if there's any ability for gift cards, honestly, it just goes a really long way and helps people feel that you trust them a little bit more. But yeah, essential socks, shoes. We get a lot of requests for backpacks. People have a lot of trouble carrying their things around, and especially warm clothing in the winter, like anything that can help with that. can go a long way. Yeah, in most places, you can get decent amounts of food through shelters and drop-ins, but getting enjoyable foods can sometimes be much harder. So that's why sometimes we will get some kind of enjoyable things, even if it's not always the most nutritious. I don't know if that's the right thing or not to do. Bobby said I did a lecture on boundaries, and it was mentioned that providing anything of material value can be a blurring of boundaries and can change the nature of the alliance. That's interesting. Um, hmm. I wonder, Bobby, if there's any way you can elaborate on that point about that it blurs the boundaries, even a book, and this was seen as a negative thing in this context. I'm assuming. Huh. That's interesting. I'd love to know more about that. I I have to admit that I find that I mean my approach has been a little bit different. I find that the boundaries are often very limiting for folks. I find that I need to do what I need to do to make them feel that they have value. So the number of patients, for example, that have my cell phone is a lot, and I've been completely surprised at how few people misuse it. To be honest. But it's interesting. And so, these are just obviously one clinic's perspective and one person's perspective. So I think there's some really good things that are coming up in the chat, but some of the stuff that might be really good for people to have. But again, small enough that they're affordable, large enough that they have enough value for people. Um, yeah. And then, I think there's someone in the chat. Oh, just guess what? See who it is. Like I think the understanding that people can have on a contingency management in terms of how to support. So that's obviously something separate that people can learn about. But the idea that people can be supported for and positively reinforced for behaviors, and some of that's even just I will always ask people what they see as their objectives, right? So yes, we do a lot of rewards for people when they're doing the things we want them to do, but I'll often ask them, what is the one thing you want to accomplish between today and tomorrow or the next time I see you? And if they're sticking to their own goals, I actually believe in trying to reward that as well. I'm going to keep going, otherwise I'm going to, but feel free to keep putting in the chat anything that might be good to provide to people. This, for anybody who hasn't seen, this is I love this work of art. It's actually an English work of art. It's called From Cradle to Grave, and what they've tried to do is take an average man and average woman and put all the pills that somebody is going to consume in their lifetime in one spot. So definitely don't want to be more than just pull pushers, but that's it. I want to talk a little bit about acute pain management, and what I'm going to say, I understand and appreciate, is probably going to be different than what you've heard from other people. But this is the approach that I believe is evidence-based, and I strongly support. I really like this paper in terms of how it framed it. I think we see a lot of acute pain management issues in in people who use drugs, and especially people who are seeking to be supported for opioid care. And I really wanted to include this actually in this presentation based on a recent conversation I'd had with one of my patients. So this actually came from a nice study that was put together. What are some of the concerns the patient has? Which I think is really important to understand. Fear of withdrawal, the fear of pain not being taken seriously, the fear of discrimination, often based on previous experiences, and in those currently absent, the fear of relapse if re-exposed to opioids. Then there's clinician concerns, mistrust. There's a very real mistrust, right? Overtreatment of pain leading to opioid-induced ventilatory impairment. The possibility, the reports of pain may be fabricated to acquire opioids, and the diversion of prescribed opioids. These are some principles of treating acute pain. Create a supportive, non-judgmental environment. Establish which drugs might be misused. Optimize non-opioid analgesia. Use increased doses of opioids compared with opioid-naive patients, but with careful monitoring. In a hospital or in the emerge, change from IV to oral as soon as possible. and make sure that you're managing withdrawal, minimize stress, allow for multidisciplinary discharge planning. This is where I think my approach, and those of some of my colleagues, is a little bit different than the mainstay. So this is another piece of artwork that I also really liked. It's an artist that took the powders that make pills and pressed them into a variety of guns because it was perceived, to the perception that how much harm painkillers have done. Um, so my approach to using opioids for acute pain is very different in those with a significant history of opioid use versus those that don't have a significant history of opioid use. We have to understand that in people who have long-term opioid use, your risk is not necessarily of creating an addiction. That addiction is already there. And unfortunately, so is their maybe different relationship with opioids than other people. I actually strongly believe that when people come in with objective things, a new fracture, cellulitis, something that's going to cause them acute pain, I think we need to be very liberal with people who use drugs with regards to acute opioid management. Often it means higher doses. It means using at least 50 plus morphine equivalents a day, often greater than 100 morphine equivalents a day for pain management. It means frequent adjustments. Doesn't mean frequent dispensing, so the person can go to the pharmacy every day or two. But the number of people that I will meet who have been long-standing on methadone or Suboxone who will tell me that they don't even dare ask their physician because of the perceived fears above is huge. And there are very few things that people experience that is as distressing to them as severe acute pain. It has caused so many relapses, so much accelerated use from what I've seen. So I think, yes, you should mitigate it in terms of more frequent dispensing, a short timeline that you agree on with the patient. But I personally have not necessarily agreed with the practitioners who don't believe it's appropriate to provide acute pain medication. These patients generally have very high tolerance. The deaths we're seeing are not from people being prescribed short-term opioids. And it's very different than leaving the emerge with a whole bottle full of them. So this is one thing that I think can build people's relationships much more strongly. And I have personally not seen significant harm, have not seen significant harm in the literature from people who receive acute pain opioids, as well as obviously non-opioid pharmacotherapy. And there's a lot of amazing things such as the growing use of ketamine in this patient population to help as an opioid-sparing agent. But I have not seen the harms from short-term opioid use, and my relationship with patients has grown stronger because they've told me that they feel recognized and valued and heard. And I tell them, if this is something that's going to be happening every month, this isn't something we can do. But people are mature and knowledgeable enough to know that if they need help, they should come to me, which is better than missing an appointment and going out and using more of something they need to control their pain. Because historically, their pain receptors are different. Their opioid receptors are different. They are people who have responded to pain with opioid treatment in the past because that's how they treat themselves. So that's my approach. I know there's more lectures today on chronic pain, and my approach to chronic pain isn't one where a lot of acute short-acting opioids, but I do think especially in the context of acute pain, I'm really saddened to see how frequently we leave patients and clients suffering just because we're afraid that they might misuse or divert a small amount of something. The last part I want to talk about is something that I think we often overlook, and I think is really necessary to make your clinic and the work you do a comfortable place for people who use drugs. We need to recognize that people who use drugs for good reasons, not always the best reasons, but they use them for reasons that either provide them pleasure or treat some symptom in some way. Drug use has enough disadvantages that if people weren't getting significant benefit from it, they would have stopped a long time ago. And acknowledging that ambivalence, that being torn, is really, really, really important. Just before I move on, Brad here saying I had a patient with a broken rib, was on methadone. He was suffering a lot. He prepared himself to have a long appointment to beg for something. Yeah, I blindsided him by being on board with treating his pain, made a grown man cry. He was very grateful. Yeah, the times of appreciation, just again, that we've seen when you're providing appropriate and with safeguards, right? You don't have to prescribe them a month that they become all at once. It can be really, really moving moments. So I want to talk a little bit about how to do a functional analysis. Some of you may know this, some of you don't. So this is a little bit about what is going on when someone uses drugs. And I do this on every single one of my clients. Most of my clients think they're coming to see me for treatment and they want to talk about all the reasons that they want to stop, which is great and super important. But I think it's really important to explore with people why they use drugs. So what are the external triggers? Who are you with, usually use with when you do? Where and when? But then as important as that are the internal triggers. What are you usually thinking about right before you drink or use? What are you usually feeling physically before you drink or use? And what are you feeling emotionally right before you drink or use? What do you usually drink or use? How much? And how long of a period do you use it for? These are borrowed from a therapeutic technique that I really like called community reinforcement approach. In addition to these functional analysis, there's some elements of contingency management. There's sobriety sampling where people just get to try it out and see what happens. There's also a lot of role playing on how to refuse drugs and alcohol because a lot of people's social circles rely on drugs and alcohol. So being able to refuse drugs and alcohol without necessarily saying cutting off those friendships is really challenging. And so being able to say, I don't want to use today, but I still want you in my life. It's actually a skill. So that's all from CRA, and then CRAFT is the CRA element that employs family therapy that supports how to help family members cope with people who are using drugs and alcohol at home. So this next part of functional analysis I think is really important. What do you like about drinking or using? What do you like about who you use it with? What do you like about where you use? What do you like about when? And then what are some of the pleasant thoughts you have, some of the pleasant physical feelings, and some of the emotional feelings? I like the way these functional analyses are wrapped up, but then they move into the long-term negative consequences because it is important for people to recognize that too. But I think understanding why people are using things is really important, both in terms of coming up with alternative things they can do, but also just help you understand that person better as they move towards it and move towards trying to make changes in their life. I know there's a lot of talks today with people with lived experience. I actually think so. Almost everything that I've heard that I've shared here is something that I've learned directly from either working with or speaking to people with lived experience. I am a big proponent of the direct and meaningful involvement and centering of people with lived experience in the work they do, in the work you do. I actually am a bigger fan of direct employment of these individuals rather than in an advisory capacity because I find the role modeling of that behavior that they will have and the things I learned to be so great and so important. And so I just want to make that little plug here. I know I'm the one here presenting, but the importance of that. There's a question in the chat from Sydney. At what point in a person's treatment would you do a functional analysis? It's like the second thing I do if I can. As pretty early on, I want to know, not only what are they there to do with me, but why, what they like. And yeah, I like that idea. Immediately and frequently, exactly, because that may change as time goes on. But it's a really big, important part of understanding people's drug use and why people use. And you pepper it in with, so the other part that I didn't have of the functional analysis is the functional analysis of healthy behaviors, which is also like all the things that they're trying to do in either cutting down or healthy behaviors and get them to try and do a very similar analysis of those things. But I like that. I like the way it's been put immediately and frequently and helping them understand. Absolutely, absolutely. So let's have a little summary I actually really like this. This is from a paper in 2017. I really like this framing of the harm reduction principles, and I think these incorporate everything I've been trying to talk about, how you can frame your clinic. So the first thing is humanism. You're understanding people are human beings, that they're all unique, and that they're flawed. We're all flawed, and I think being understanding and recognizing that, and even acknowledging that to the clients is really important. I don't know why some of our clients feel that they have to behave perfectly for us, but I think trying to dispel that is important. Pragmatism: grab what you can, be realistic. I think having plans is really important. If you've asked somebody to come to an appointment 20 times and they can't come on time for an appointment, you got to be realistic that it's not going to happen. So maybe your admins or maybe the people that support you don't normally call somebody before an appointment, but maybe this is somebody that needs that call the day before. Maybe this is somebody that you need more of a drop in for. So a little bit more pragmatic. Individualism, the approach for everyone needs to be different. Autonomy, I hope that goes without saying, just the necessity of respecting people's autonomy in their decision making, but also that might mean that what they want changes every day. It's about not making assumptions either. We might have a client who has had a terribly traumatic history, but their use may actually have nothing to do with their trauma. We make assumptions and we have biases in one way or another, and really allowing them to express it themselves is key. Incrementalism: things happen slowly, they don't happen overnight. And so, especially when it comes to looking to change behaviors that might be problematic in your clinic, I think sometimes we can get into a habit of creating contracts with patients. They had an outburst in the clinic. If you have another one, we'll deny you care or something like that. I don't think those work particularly well. I think looking at stepwise improvements make a lot of sense. And I think recognizing, for example, if we're going to implement service restrictions, you have to be very, very careful. And so this last part of accountability without termination. This is something also that not everyone agrees with, but I feel that termination of clients from clinics causes ruptures um, amongst providers, but also, unfortunately, I think leads to a lot of deaths and harm where people's prescriptions are suddenly stopped. But there are a lot of ways that you can institute accountability without necessarily terminating them. Come back when you're not intoxicated. If you don't come in during the time that we had said you wanted to come in, then you won't be able to have an increased dose, but will at least bridge your dose. Things like that. What is the safest thing I can do for somebody without necessarily terminating them? And then again, like kind of pragmatic things that you can do and physical things you can do in your clinic. The last thing I just want to mention about ambivalence and going back and forth is the reality that the degree to which harm reduction versus treatment that you offer for a single person in whatever context is likely to change from day to day. And being able to create an environment that supports them however they want is going to be really, really key, and that may change from one day to the next, which is why things like a functional analysis, things like exploring their needs, things like creating them an environment where they can safely be and be comfortable are all really important. And as much as possible, if you can link it to the patient's goals. So that's it for me. I hope a lot of this makes sense. And please continue to add her into the chat some ideas or things that you've had. I'm hoping maybe now we can also have some question and answer and see if there's anything either that I missed or that you'd like me to elaborate on. But I hope that we've been able to cover some of both the structural things, some of the step of the clinic, some of the things that you as the provider aren't involved in normally, but need to start looking at, and some of the key population groups we're missing and that are dying, including people use stimulants, people in the construction industry, and people with acute pain whose relationships with primary care is being torn around in different ways.
No, as you, Alex said, if you have any questions, feel free to include in the chat. Thank you so much, Alex. That presentation was excellent, and it gave me a lot of food for thought. Even simple thing like the question you asked about to imagine like what are clinic weight room looks like. And a simple tip like moving people to low stimulus area, I feel like certainly something I intend to implement in my practice. Brad had commented something about
Oh yes.
engineering
Oh,
the
you can
clinic
read after.
to build intolerance for patients that struggle with appointments rather than berate them for being late. And it's a good point for sure.
Yeah, no, this is absolutely true. And you know what? This is again where explaining stuff with transparency is going to be really important. Um, the more transparent you are about what you do and what you don't do is important. I find, my God, I'm like always shocked at how understanding people are when you explain at least why you can't do something. And I'm sure a lot of you are already doing that. But especially when we see somebody in distress, we want to react in kind of an equally emotive way, and sometimes that can be really limiting.
Absolutely. Alan asked any tips on advocating for change in one's clinic, like changing lighting levels, hours of availability, etc.
Yeah, so there's I think there's kind of two different ways that I've seen people do it. I think a smaller QI project is a great opportunity, and a lot of institutions, if you're part of a hospital or a university, will have small pockets of funding, and they're not particularly expensive things to do, like around changing lighting or this or that. And so doing like some PDSA cycles um, and things like that can be really important. I think the other thing that's very powerful is the voice of clients themselves. The more they can be written down and understood, the more powerful it is to bring them to leadership. So it's one thing to say, you know what, our hours are just not working for people. It's something else if you are either able to get a group of your clients or people that have experience together to get some of this down on paper, or if you're able to go to another community agency or a nearby community agency and even just piggyback on one of their meetings periodically or their advisory meetings, which we've done in the past, to just ask them. So I'll tell you, for example, like at St. Mike's, we had a big problem with with security a few years ago, and they were adamant about certain things that were happening or not happening. We worked with some advocates in the community to bring people in, and what we just did is we put the leadership in the same room as those individuals and let them talk. And it becomes a lot harder to say, we can't do X to a person who's telling you they were just kicked out of a building without shoes in the middle of February than it is in an otherwise time. So as much as you can, if you can either put in writing or put your administrators and bosses in the same room as people with lived experience, I mean, it fulfills some of our role of facilitating, speaking truth to power, but the other part is when people hear it straight from people, it's really, really hard to say no. We've in one of the clinics we're working at, we've been trying to track more reliably the number of times people come after hours. The number of times, so that's not something we track regularly, right? But I want to know how many people come in 5 minutes after we close the clinic, because those aren't patient failures. That's a service delivery failure, and how we need to and are going to address that. What else? Brad also brought up better ask for forgiveness, beg for permission. Yeah. Assuming the barrier is other people saying no to the changes. Yeah, absolutely. Um, any other questions people have?
Yeah, it's so interesting, especially as people are trying to work towards their recovery and have functional goals or functional obligations, how clinic hours can be limiting in terms of their capacity to engage in care.
And the consequences are very different than they used to be, right? Like
Mhm.
the consequences of a missed dose, the consequences of a missed appointment, the chances that they result in death now are very, very different. And
Absolutely.
yeah, and so that kind of do no harm part of what we do, I think the paradigm has shifted a little bit and our responsibilities have shifted.
Mhm. That's great. Brad mentioned they have a cell phone the patients can call or text. Yeah, it's interesting, Brad. I feel like in some ways, COVID, I think, really helped modernize medicine and like using different forms of technology to be able to contact patients and other things that might have taken like another 20 years.
Yeah, absolutely.
Yeah,
That's interesting, Natasha, not having a camera. I don't know how your clinic's been, Karen. We haven't had one, and we've chosen not to have one either.
we don't have camera. There is like a two-way glass mirror, but it's not a regular practice at our clinic to do observed UDS. I think the autonomy part that you spoke to, and just like um, I can't even think of honestly a situation where I work at CAMH where we've used observed UDS.
I'll tell you one thing. Like, I don't know. I probably shouldn't say this because I don't. But like, I have never seen the college get somebody in trouble, especially since the methadone audits have really stopped, in which the person carefully documented their belief that what they were doing was in the patient's safety's best interest.
Yeah.
Um, oh yeah, so that's true. So sometimes with CAS involvement, there's a different standard of care, and I understand it, and clarifying that can be really important. But I do find that at least for when it comes to physician, and I don't know as much for nurse practitioner legal responsibilities, but I do have to admit that in the vast majority of time, it's like they want to make sure that you've considered both sides and what you feel and are able to justify that what you're doing is safest. And that's kind of my approach when it comes to the acute pain. It's my approach when it comes to take-home doses. It's my approach with different things. If you think what you're doing and able to, in a fair way, justify what you're doing to be the safer of the options, then that goes a long way. And you're right, Brad. Unfortunately, when outside services force us to do stuff, it can create an adversarial relationship. Sorry, Karen, you were going to say something there.
No, I was just agreeing with the point that you were making. If there are no more questions, I just want to thank you again, Alex. That was a really great presentation. And as I mentioned previously, I feel I've learned a lot of tips that I can already think of making some small changes in my practice.